25-year-old medical student developed dyspnea while playing basketball and came to consult the doctor.
Wait a minute. Medical student developed. Is there a word before dyspnea?
Developed dyspnea.
Yeah, there's one more word. I don't know how he missed it. Sudden onset of dyspnea while playing basketball. That means when he started playing, he didn't have dyspnea. Halfway through, suddenly he became dyspneic, and then he has come to consult the doctor. So, what is your differential diagnosis at this point?
Sir, acute dyspnea can be caused by airway obstruction.
Due to
Airway obstruction.
due to
Airway obstruction
airway obstruction due to what?
due to foreign bodies.
Foreign body.
Or
While playing basketball, unless he was chewing some bubble gum, chances of getting foreign body is rare, but it's still possible. Okay. Foreign body is more
anaphylactic
common in people who are old
young age.
or very young children. So, mouth guard may be going into the throat, is it? I don't know. I have not played with a mouth guard, so I do not know. Maybe that's a good idea. Anyway, foreign body is a good suggestion. Anything else you want to say?
Due to anaphylaxis.
Anaphylaxis is a very good suggestion. Yes.
Due to asthma.
Bronchial asthma, it doesn't come within seconds. See, when you look at the onset of dyspnea, we have onset of dyspnea occurring within seconds to minutes, occurring within hours, occurring within days, and then months. And here comes a patient who has, while playing, has got problem. So, what it can be?
Pneumothorax.
Pneumothorax is a possibility. Any other condition which can produce sudden onset of dyspnea?
Pulmonary embolism.
Pulmonary embolism. So we have got couple of differential diagnoses with you. So we are going with this history. Okay.
No past history of any illness except one similar episode 1 year back.
So
No.
so you have given 4 differential diagnoses now. The past history of similar illness before. What are the possibilities that comes to your mind? Foreign bodies can be recurrent. Anaphylaxis can be recurrent. Pneumothorax can be recurrent. Can pneumothorax be recurrent?
Yes, sir.
It can be recurrent. And last possibility is the pulmonary embolism, that can also be recurrent. Okay.
He's non-smoker.
So does it help you in any way?
If he is a smoker, there can be a chance of lung collapse or atelectasis of the lung
Due to
um, due to emphysema or
emphysema occurring over within seconds time.
no, sir.
Smoker always go along with the COPD, bronchiolic carcinoma, and complications arising therefrom. So he is not possibly having any such combination. He has no other respiratory or cardiac illness in the past.
Yes.
Okay. On examination.
On examination, he is dyspneic.
How do you know he is dyspneic?
Respiratory rate would be higher and um, presence of pursed lip.
Pursed lip breathing may be there. Any other method by which you say that patient is dyspneic? He may be sitting up, propped up,
In tripod position.
His accessory muscles may be working,
Acting.
and he may be on O2 inhalation as well. Okay. He is not anemic.
No pallor, no cyanosis, no clubbing or lymphadenopathy.
What does clubbing do in a case of respiratory problem?
Respiratory causes of clubbing can be due to bronchiectasis, empyema, interstitial lung diseases, bronchogenic carcinoma.
Can any one of them produce complications, producing acute dyspnea like this? Anyway,
Bronchogenic carcinoma can cause pneumothorax, sudden
very,
pneumothorax.
very, very, very rarely it can produce. Okay. No lymph nodes.
Tachycardia is present. Pulse rate is 94 per minute. Respiratory rate is 22 breaths per minute.
When do you say
Blood pressure.
tachycardia? When do you say patient is having tachycardia?
more than 30 breaths per minute.
No, that is respiratory rate. No, tachypnea you mean? Or tachycardia? What are you talking?
Increase in heart rate.
That is tachycardia. So what should be the value above which you say?
100.
100,
100 per minute.
100. Okay, right. Hmm.
Yes. Blood pressure within normal limits.
Which position the blood
Yes.
pressure is taken here?
Sitting position.
Sitting position, blood pressure is normal. Yes.
20/80 millimeters of mercury.
Hmm.
Temperature is febrile. No elevation in JVP.
Right.
SpO2 is 96.
Is it normal SpO2?
It is slightly reduced.
How much you want?
98.
That's a good as idea, but commonly you'll have only 96 and all. Okay, 100% is okay, but 96 is good enough. Yes. Height?
Yes, sir. Yes, sir.
Height?
Height is 6 feet 4
In
inches.
your class, who is the tallest and what is his height?
Um, Joel will,
How much? How tall he is?
uh,
196 is how much? 6 feet few inches. So for Kerala standards, for Indian standard, this is the tall person. So what is the differential diagnosis of tall people?
tall people, they can have aortic dissection, Marfan syndrome.
Tall stature is a component of which all diseases? Marfan
Connective
syndrome,
tissue,
correct. Marfan syndrome, correct. Any other?
connect, connective tissue disorders, acromegaly,
Acromegaly only your this periphery. Acro means your limbs will be affected.
so
Okay.
pituitary adenomas causing increased secretion of
Hypopituitarism occurring in childhood, that's called as gigantism.
yes.
In adulthood, it's only the extremity that grows. You call it acromegaly. Okay. Yes. Then,
So pituitary adenomas causing
not
increased
it's a
secretion of
hypopituitarism. Hypopituitarism. Okay, right.
hyperpituitarism.
Hyperpituitarism occurring in childhood produces gigantism. Hyperpituitarism occurring in after the epiphysis is fused, you cannot have linear growth, in which case your limbs get enlarged as the peripheries, called acromegaly. So hyperfunctioning pituitary before the epiphysis is fused can have linear growth. So you may be having tall stature. Okay. And when the pituitary is not functioning from childhood, you get short stature. But if the pituitary is not functioning in adulthood, stature will be as of a normal adult. Any other condition where you can have tall stature? So you said Marfan syndrome, you said hyperfunctioning pituitary from childhood.
Klinefelter syndrome.
Klinefelter syndrome can be unusually tall people. What are other features of Klinefelter syndrome?
They would be obese.
They are obese. The hair growth will be less. They will have gynecomastia. Their testes will be small but very firm. Very firm. Silky skin. And the carry angle will be larger. Okay. Some of them may be having little bit of deficiency mentally, but borderline. Otherwise intelligence is almost normal. How will you confirm it?
By karyotyping.
If you don't have facility for karyotyping, do you have any alternate option?
Bar
Bedside.
body examination.
Where will you demonstrate bar body?
Cheek cells.
Pardon?
Cheek cells or
Buccal
neutrophils.
mucosa. Don't say cheek. Cheek is outside, no skin. Buccal mucosa scraping, or one more option.
Neutrophils.
Neutrophils, that's good. Neutrophils also you may see. So any other condition where you can have tall people. Homocystinuria is another situation where you find people are unusually tall. Okay.
Yes.
So you said Marfan syndrome, pituitary problem, homocystinuria, and Klinefelter syndrome. Okay. So this person was particularly tall. Yes.
He's thin built.
Thin built.
BMI is 19.
Is it normal?
No, sir, it is reduced.
How much you want for adult males?
Uh, 20 to 25.
Pardon?
Bet- Between 20 to 25.
For Asian standards,
22 to
23 is the
25.
upper limit. 20 is the upper limit. From 18 onwards, you can say normal. This is normal. Okay. 18 to 23 is normal one. This is okay with us. 19 is very good. Okay. No edema.
No edema or nicotine staining.
No nicotine staining. Yes.
Upper respiratory tract is normal.
Okay. What's upper respiratory tract?
Um, it begins from nostrils to vocal cords.
Vocal cords. Okay. Right. So if you want to do the review system of our upper respiratory tract, what are symptoms you'll ask? Starting from nose.
Sir, I will ask about rhinitis,
Rhinitis, sneezing,
sinusitis,
sinusitis, very good.
um, wheeze, history of
What
wheeze,
about pharynx? Pharynx.
changes in the voice,
Will they have do you have sore throat? Yes. And you may have postnasal drip. Okay.
yes,
You may have tonsillitis. Okay. Then just below that you have got the larynx. What symptom you get?
change in voice,
Change in voice. You may get stridor. Okay.
yes,
Up to vocal cord you may have these problems. Okay. So you may have laryngitis, pharyngitis, sinusitis. Okay, rhinitis. So many things are happening. Then
there is decreased movements of right chest.
so what does it mean to you? How do you analyze that?
Decreased movements means that there is some lung pathology in the right
Right
side.
side. That's good. Very good. Okay. Then
Then trachea is shifted to the left.
so what is your inference now? The first and 2
It might
points together.
uh,
Diminished movement
it might be something that pushes the lung
to the
towards the left,
left side, like
like pneumothorax
or
uh, or pleural effusion.
pleural effusion. Okay. Then
Then a scar is seen in the fourth left intercostal space in mid-axillary line.
what are the scars commonly seen there?
Uh, the scars can be due to intercostal draining from a previous
That is good.
pneumothorax.
That is good. Yes. That's the commonest scar seen over there. Okay. Then
Then vocal fremitus is decreased on right side.
so what are the causes of decreased vocal fremitus? With pushing to the opposite side.
Pneumothorax.
Pneumothorax.
Then emphysematus bullae, large
Bulla. Uncomplicated bulla shifting to the opposite side is not very common. What about pleural effusion? Okay, yes. Then
hypervescement not on the right side.
so what do you make out now?
Pneumothorax.
Pneumothorax. And what is happening?
The air in the pleural cavity is pushing the lungs
Hmm.
to the left side, and
Hmm.
there is no passage of air to the right side.
Okay, so you got this patient as a case of pneumothorax. Okay, now tell me what are things you specifically look for to find out the etiology of this condition. General examination, you said there is no nicotine stain, so possibly not a smoking related disease. He has no clubbing, so clubbing related bronchiectasis, lung abscess, carcinoma are unlikely, can occur. There is no clue about it. Now JVP is not raised, that's also given, no? What do you make
Yes.
out of that?
There is no cardiac pathologies involved.
So when in a case of pneumothorax, when JVP is raised, you will suspect tension pneumothorax. That is not there. And tracheal tug is absent. So what is tracheal tug and how does it come here? If tracheal tug is present, how does it help you?
It means that something is pushing the trachea. to downwards.
Tracheal tug indicates that two possibilities. One is a fully expanded lungs, where lungs cannot expand horizontally thereafter, so only the diaphragm is moving up and down. Alternatively, it may be an aneurysm of the aorta, arch of the aorta, or the bifurcation of the trachea and pushing it down each time the heart pulsates. So tracheal tug, we have only two possibilities. Tracheal tug is not present in this case. Why do you are looking for tracheal tug in this case?
Because that could reduce the aortic dissection.
No, that may be a clue that this patient is possibly having emphysema, emphysema bulla, and thereby producing pneumothorax. That's why the importance of tracheal tug comes. Okay, so you have got a basic diagnosis of pneumothorax. How are you going to confirm the diagnosis?
By chest X-ray.
Chest X-ray, you want the sitting position, lying position, or left lateral, right lateral? Which position you want the X-ray chest?
In sitting position.
You want in
LP as well as lateral.
you want the pneumothorax X-ray in the standing position if the patient can stand, or sitting position. Otherwise, okay, commonly is taken in the standing position. So you commonly do X-rays in inspiration or expiration. Normally,
Inspiration.
inspiration, full inspiration. Is there any special instruction for this particular patient?
We ask them to inhale fully, and then we will take the X-ray at inhale positions.
Yes, when you take deep breath, your lung is maximally expanded, so minimum amount of pneumothorax may be missed. So commonly, if there's a doubt of minimum pneumothorax, the better option is to ask the patient to expire, so that the pneumothorax will be maximally expanded and you will be able to see. Anyway, normal X-ray inspiration is good enough for early part. So once you have got the diagnosis of pneumothorax, our attempt is, how do you classify pneumothorax?
Can be classified as primary and secondary.
Before you classify primary and secondary, we have to think whether it is spontaneous or traumatic. Spontaneous is again classified into primary and secondary. Okay, so first classification is traumatic or spontaneous. Traumatic can be again classified into iatrogenic and otherwise. What are the iatrogenic causes for pneumothorax?
It can be due to intercostal drainage.
No. Intercostal drainage is already done for something else.
So for biopsy,
Commonly, medical wards, we do a central line to subclavian vein. There's apex of the lung that is coming in contact with subclavian vein, and there's every chance that you have injure the pleura and you may get a pneumothorax. So central line is very important thing. Second thing, if you are doing a biopsy transcutaneously for a peripheral mass, you may get it. You may do other procedures like bronchoscopy, transbronchial biopsies, EBUS. So procedures are commonly done which can be the cause for iatrogenic type of problems. So in medical wards, we are not doing bronchoscopy, we are not doing biopsies like that, but we are involved with the CVP line. And another scenario in ICU where you are ventilating the patient, if the pressure increases, the alveoli may rupture, and you call it as barotrauma. That can also produce pneumothorax. So that is one important thing for us, those who are in ICU. Okay. Other things commonly done by the pulmonologist or radiologist, and we are just part of it. Now coming to the non-iatrogenic cause of trauma, what are they? Non-iatrogenic cause of trauma, stab injuries. Somebody playing football, hit, and you get a fracture of the rib, and you may get pneumothorax. So blunt trauma or penetrating trauma can produce. Coming to the spontaneous variety, you said primary and secondary. What is primary?
Primary is most commonly idiopathic primary spontaneous pneumothorax.
Primary is where there is no underlying lung disease, and secondary is where there is underlying lung disease. So, what are the common underlying lung diseases producing secondary pneumothorax?
Interstitial lung diseases,
Say common things first.
malignant infection,
COPD with emphysema tops the list. COPD with emphysema tops the list, followed by tuberculosis as the next cause. Cystic fibrosis is rare. Bronchitis producing pneumothorax still rare. Pneumocystis producing bronchitis rare. So underlying lung disease may be there. Very rarely you get a for carcinoma or infarction and all. So COPD is the topper. Okay, emphasis followed by tuberculosis. So leave aside this particular boy, medical student, healthy guy, was playing basketball, so he is possibly having primary pneumothorax. So looking at the primary pneumothorax, how do you subdivide further? You can have closed type of pneumothorax. What do you mean by closed? Closed pneumothorax means an opening is made in the pleura, air has leaked into the pleura, and then that opening got closed. So air has leaked into the pleura, but then that opening is sealed, no more air will take place. So if you measure the pressure of the pleura inside the pleura, it will be lesser than the atmospheric pressure. This is the closed pneumothorax. Second variety is open pneumothorax. What do you mean by open?
There is an opening with the external environment through which air can.
External environment means?
Atmosphere.
No. The opening is between pleura and the bronchus. The fistula you are talking about takes place when there is a stab injury. Okay, where the mediastinum can flutter with inspiration expiration. But here the fistula is taking place between bronchus and pleura. This is called bronchopleural fistula. The problem here is air enters the pleura, but the advantage is it goes back to the bronchus, which will not build up the pressure inside the pleura. In other words, the pressure inside the pleural cavity will be same as the pressure in the atmosphere. Got the point? So how will you recognize clinically bronchopleural fistula?
You might not be wearing fingers or.
You auscultate the chest and you are likely to get amphoric breathing. So this is the characteristic feature. What is amphoric breathing?
There will be increased. That sounds.
Amphoric breathing is a low pitched bronchial breathing with a metallic quality, as you get in a large mouth, large cavity. Okay, so this is the pattern in bronchopleural fistula. The last variety is called as
Tension pneumothorax.
otherwise called one-way valve mechanism, where the air enters the pleural cavity but will not go back to the bronchus. So each breath more and more air enters the pleural cavity, so pleural pressure will be more than the atmospheric pressure. So what are the consequences of this type of collection of air?
It can lead to lung collapse.
It leads on to lung collapse. Not only lung collapse, it presses upon the drainage veins. Draining veins will be pressed upon, so blood will not go to the heart. Obviously the cardiac output will go down, and you will find that the reflection of this pressure on the veins will be seen on the JVP. JVP will be raised. So symptom wise, progressive worsening of dyspnea, and we look at the pulse, you get classical pulses paradoxes, low blood pressure, you get raised JVP. In this scenario of pneumothorax, you make a diagnosis of tension pneumothorax. This is an emergency, requires immediate attention, patient survives. But there are very few situations where you have this combination of raised JVP with hypotension. What are the possibilities? that will come as your differential diagnosis for tension pneumothorax. What are they? Raised JVP with low blood pressure, massive pulmonary embolism must come. It is exactly like this, sudden onset. Tension pneumothorax is a second possibility. And when you have right-sided myocardial infarction, you may find the blood pressure is low and JVP may be raised. Okay, pericardial tamponade is another situation where you may have same problem. Last but not least is very severe right heart failure. Terminally you find blood pressure also goes down. So this is how you look at this patient. So you have gone for the X-ray. Do you want to do any more investigation other than X-ray? Do you have any other investigation?
Spirometry?
No, spirometry and all very difficult. No, difficult. And when the patient is dyspneic, it may not be possible. You have to do an SpO2 at least. Blood count ESR may be done. Okay. So this is an emergency situation. So you have to intervene. So the question is, what are you going to do next for this patient?
We'll give oxygen
Yes. Why do you want to give oxygen?
because his SpO2 is decreasing.
SpO2 is normal. Why do you want to give oxygen? Whether SpO2 is decreased or not, oxygen is mandatory for these patients. Okay. But in atmospheric air, what is the concentration of oxygen? What's the concentration of nitrogen?
21%
Okay.
oxygen.
So
and
pleural air in pneumothorax. What's the concentration of nitrogen and oxygen? Same. So by giving high concentration of oxygen, you are trying to increase the concentration of oxygen in the blood. Thereby, you will find that nitrogen by diffusion will go into the blood. Got the point? Yes. So that is how you are going to utilize administration of oxygen. So you can give oxygen. Whether you treat or not, this pleural air will get slowly absorbed. And if there's a 15% pneumothorax on one side, it will get absorbed normally within 3 weeks time. There is no much delay about it. So the question is whether you want to admit this patient or you want to send him home.
if he's symptomatic, we should admit the patient.
Yes. If he is if he is symptomatic, he needs attention. 2. If he is above 40 years, he needs attention. 3. If he has underlying lung disease like emphysema. 4. If he has got previous history of pneumothorax. 5. If he is dyspneic, then he needs more care. Otherwise, you may assess the severity of the pneumothorax by measuring it. There are different techniques of measuring the volume of air. None of the methods are satisfactory to all different associations world over. Different people follow different guidelines. A common basic rule is, if you measure the amount of air at the apex of the lungs in X-ray, it is more than 2 centimeters, it is more. Less than 2 is mild. All depends upon whether the patient is symptomatic, the underlying lung disease or not. Even if the pneumothorax is very, very small, if the patient has already got some disease like COPD, then minimum amount of pneumothorax will create lot of dyspnea in that patient. Okay. So who are the people who are going to admit above 40 years? Above 40 years who have got disease otherwise, previous history, diseased lung, patient must be admitted. And what will you do?
Oxygen therapy initially,
And then what next? Oxygen is going on. What is it do next?
thoracostomy,
Commonly you put a cannula and aspirate. So first step will be aspiration for this type of, yes, not needle, it is a cannula that's used for aspiration, and you remove as much as air you can. And repeat X-ray and see what is happening. The patient is improving. After 6-8 hours observation, patient is absolutely well, no dyspnea, successful aspiration. Then these patients are likely to go home. Otherwise, they need to be admitted and keep on aspirating till they become okay. If the patient is not becoming better, repeated aspiration with a cannula, this patient must have a underward seal drainage. Also, all bilateral diseases needs drainage. All previous diseases, previous pneumothorax, underlying lung disease, very much dyspneic needs underward seal drainage. But in case of pneumothorax, if you organize the drainage, it takes time. So tension pneumothorax is a scenario where you cannot do it. So what will you do?
Thoracostomy.
No, the thoracostomy takes time. You just take an ordinary injection needle and pass into the intercostal space, and excess air will leak out. And then you organize for the underward seal drainage, but emergency measure must be given. Okay. So, uh, how does this emphysema produce pathogenesis? How does it produce a pneumothorax?
Um, Normally in the pleural cavity, the pressure is negative. Intrapleural pressure is negative.
Commonly, they have got what's called as small blebs at the apex of the lungs. Okay, these blebs get burst into the pleural cavity, producing pneumothorax. Okay. Okay. So, do you do commonly the CT scan for these patients?
Yes, sir.
Pardon?
Yes, sir.
No, CT scan is not commonly done unless it's a complicated type of pneumothorax, very much encysted pneumothorax, or it is following a trauma. You may go for CT scan. Otherwise, X-ray chest is good enough. Okay.
Yes, sir.
So, how long you will drain? Underward seal drainage for how long?
Um,
At least for 24 to 48 hours after the air has stopped leaking. You repeat the X-ray and then decide. This particular patient discussion had previous pneumothorax. So, what do you mean by recurrent pneumothorax?
mm, More than
Two, three or more is called as recurrent pneumothorax. So, what will you do about that?
pleurodesis.
Pleurodesis can be done. What are the common substances used for pleurodesis? Talc can be used, bleomycin can be used, tetracycline can be used. BCG is another option to induce inflammation, and then you can close the pleural space, but will produce adhesions. With this patient had right-sided pneumothorax, and we said there can be bronchopleural fistula. You can diagnose it by auscultation. Now tell me, what are the important things in the examination of a pneumothorax on the left side?
On the left side, on examination, the left-sided chest movements will be decreased.
No, all the findings of pneumothorax will be there. In addition, what special is there? You may find clicking noises over the apex beat. When if there's a pneumothorax, some cases you may be getting clicking noise. Command sign may be elicitable. And if the pneumothorax has leaked to the subcutaneous tissue, when you palpate the anterior or lateral side of the chest, even posterior, you may get a crepitus because of
Subcutaneous emphysema.
surgical emphysema, subcutaneous emphysema. Okay. Now you said this particular patient is very tall, so you even get differential diagnosis. So how will you go to diagnose of Marfan syndrome?
Um, Genetic mutation studies.
You are a molecular biologist. Eh? We are clinicians only. We have to go for clinical. Eh?
Other clinical features like high arch palate.
Yes, Marfan syndrome is autosomal dominant disease. So you may take the family history first of all. Second, there may be history of other complications like dissection of family members. But Marfan syndrome can occur because of mutation also. The family history may not be always be possible. some measurements you take. What are they? High arch palate may be a inter observer, but a limb span will be more than
arm span.
arm span. So, limb span will be more than arm span,
The arm span will be more than the height.
more than the height. Okay, so there's a relationship between them. Okay, what about upper segment, lower segment?
It will be increased.
So how do you measure this
Ratio.
upper segment and lower segment?
Mm. First, we measure the lower segment from pubic symphysis to the medial malleolus, and then we will subtract this upper segment from the height.
Height. So
From
you
the
get the,
lower
so that's one way to look at the Marfan syndrome. So you look at the height, look at limb span. 2 points are there. Then anything with your fingers. What happened to fingers of these patients? Is it short
segment.
or stout?
It will be long.
What's the term you the term you call for those?
Eighth
Arachnodactyly. Arachnodactyly. Okay. So two signs you can elicit there. What are they?
ape sign.
Two sign. One is wrist sign and one is thumb sign. What is meant by thumb sign?
When we flex the fingers, the thumb will protrude outside.
How much the thumb should protrude outside? Minimum of one distal area of the thumb, distal to the distal interphalangeal joint, whole distal phalanx must be outside. Whole distal phalanx must be outside. Okay. Second criteria is wrist sign. What is wrist sign? Wrist sign.
Also,
You catch hold of the wrist with your little finger and your thumb, and it must overlap the nail. Okay,
yes, sir.
it must overlap the nail of the little finger. Thumb must overlap completely over the nail. Then you call it as arachnodactyly. There can be other skeletal manifestations like
Bossing of head.
there can be pectus excavatum, there can be kyphosis, scoliosis, flat foot or arched foot. Arched foot may be there. Then you may have sometimes striae may be there. Okay. Additionally, you may get some cardiac manifestations like
Aortic dissection, cardiomegaly.
aortic regurgitation, aortic dissection, or MVP. Yes, and you look at the eyes of these patients, as you learned in ophthalmology, you may
There
get
will be dislocation of the lens,
laterally or medially
posterolateral,
or upwards.
upwards.
Upwards, okay. It can move upwards. Okay, so that's how you conclude that clinically it is a case of Marfan syndrome. As you rightly said, there are genetic studies. So, what are the genetic studies you would like to go to?
Mutations in collagen genes like cola R1.
Okay, so you may go for a mutation study. And how is it going to help you? How is the mutation study helping you?
In categorizing the disease,
Yeah,
genetic counseling.
yes, genetic counseling may be helpful by doing the mutation studies. Okay, if you leave these patients alone with Marfan syndrome, these genes are called FBN1. Okay, FBN gene mutation may be there. Okay, so there are different criteria laid down. If you got this mutation alone, you cannot make a diagnosis. If there is a mutation plus you have got lens abnormality, you may make diagnosis. If there's a mutation plus your aortic problem, you may make a diagnosis. If you don't have genetic studies available but aortic is there plus lens dislocation is there, you may make diagnosis. And there's a list of combinations scoring system in which you find the scoring system is more than 7 plus aortic involvement, again you can say it is present even without the studies. So the scoring system and all, you need not worry. Scoring system is all the points we just told just now. Okay.
Yes, sir.
So that's all about story. So don't worry about the criteria and all. You must know there's entity like this. How do you differentiate this from homocystinuria?
Bio- Biochemistry assays will show elevated levels of homocysteine.
See, you are interested in laboratory work. I am asking clinical work. Just like Marfan syndrome, clinically, what do you think is the difference between them? Lens will be moving downwards in case of homocystinuria. Marfan syndrome, lens is moving upwards. Mental retardation is a common feature of
Homocysteine.
homocystinuria. And when you learn about hemiplegia and all, I am sure somebody told you about homocystinuria, young stroke and all. How are they connected? There is a prothrombotic state. Homocystinuria, they are a prothrombotic state and they are likely to suffer with venous and arterial
Thrombosis.
thrombosis. Okay.